Good morning everyone. Ingat tak?
Kurang jelas.
Kurang jelas kan?
Okay,
Good,
okay, now better. Okay.
good morning everyone. So today I would like to present regarding the hypovolemic shock lah.
Mm-hmm.
So first we go with definition. So for hypovolemic shock is an emergency condition in which there is a severe blood and fluid loss make the heart unable to pump enough blood to the body due to the decreased preload. So the pathophysiology in hypovolemic shock is start with hypovolemic. It will cause a decrease in the venous return and then will cause a reduce in the preload and thus reduce in the cardiac output which lead to hypotension. So in the hypovolemic shock, there will be a multi-organ failure which can lead to organ dysfunction. So these both can lead to reduced perfusion and subsequently will cause to hypoxia. So causes for hypovolemic shock, we can divide it into hemorrhagic and non-hemorrhagic. So for hemorrhagic, there will be external blood loss lah, wounds, open wounds, acceleration of internal bleeding like hematemesis, melanic, epistaxis and hemoptysis, any internal bleeding or like hemothorax or hemoperitoneum and traumatic shock. For non-hemorrhagic, we can divide it for digestive loss like patient persistent vomiting, persistent diarrhea, nasogastric suction, digestive fistula. For renal loss in a patient with diabetes mellitus, polyuria that caused by the diuretic overdose, osmotic substances, polyuric due to acute renal failure, skin loss like burns lah, and then third space loss such as peritonitis, intestinal occlusion, pancreatitis, ascites, and pleural effusion. So hemorrhagic shock can be divided into few classes lah. We have class 1, class 2, class 3 and 4. So in class 1, the blood loss is up to 750 and the pulse rate will be less than 100 with a normal blood pressure and the respiratory rate within 14 to 20 lah. Urine output more than 30. For class 2, the blood loss amount range between 750 to 1500 and the pulse rate is range between 100 to 120 with normal blood pressure but the respiratory rate up to 30 and then the urine output also range between 20 to 30. For class 3, the blood loss will be between 1500 to 2000 and the pulse rate more than 120 to 140 and then the blood pressure start to decrease lah, lowish and then respiratory rate will be more than 30 and then urine output is within 5 to 15. In the class 4 of hemorrhagic shock, the blood loss will be more than 2000 and then pulse rate will be more than 140 with lowish BP and then the punya respiratory rate pun dah more than 35 lah and then urine output is negligible. So at the stage 4, patient start confused lethargic semua lah.
So why is it important to know this classification? Sebab apa? Yang ni semua kena tahu lah. Before all this.
For resus tengok kan?
Untuk apa? Sorry?
Bukan for resuscitation ni.
Yeah, okay, see when the patient comes to you, usually in terms of blood loss or percentage, sometimes kita tak tahu. Maybe kalau patient ada trauma happen at their side. So datang kita tak tahu blood loss dia banyak mana. Okay, so if you see in class 1, generally it's normal. Kan class 1 macam normal patient kan? Normal patient. Okay. So what this actually table show is that for any patient yang you suspect shock, these are the parameters that you need to look. So even if you give fluids, you give your blood, nanti you kena tengok balik. Heart rate dia turun ke tak? BP dia macam mana? Is it coming down? Is it increasing or not? How's the respiratory rate? These are things which you need to monitor. Okay, between 2 and 3. Okay, so previously, if 3, it means that you need to you have to prepare your blood products. If 2, you dah kena consider of giving blood products. This is for kalau in a bleeding patient. Okay, so this is how you want to actually recognize. Most of the time, kalau patient 3 and 4 is very obvious. Kita dah tahu patient ni dah memang in shock. So the subtle one yang kita kena catch is when patient is in class 2. Class 2 tu you dah kena think. Okay. Okay, never mind. Can go to next slide.
So, clinical signs in hypovolemic shock can be divided into compensated and decompensated lah. So, in compensated, the mental status was anxiety, skin look pale, and breathing less than 30 minutes lah with pulse less than 120 and blood pressure more than 100 mmHg. For decompensated, we can see that the patient started to lethargy and then pale and cold and sweaty skin. Pulse rates, breathing start to accelerate more than 30 and the pulse rate tachycardic with lowish BP juga.
Jadi kalau decompensated is like 3 already 3. Compensated is maybe 2 class 2 Decompensated class 3. Okay, next.
So this is the overview lah that usually hypovolemic shock patient maybe can present with cardiac tamponade where the blood accumulated around the heart in the pericardial sac or any fracture that caused a massive blood loss lah.
Then cardiac tamponade causes hypovolemic shock
Can
Yang cardiac tamponade what kind of shock?
Cardiogenic.
Cardiogenic. Lagi? Selain daripada tu?
Shock cardiac tamponade.
Hemorrhagic shock.
Hemorrhagic. What other types of shock that you know? Okay, just now kita belajar septic shock, then you got hypovolemic shock. Then what else? Kita ada neurogenic shock. Then apa lagi?
Cardiogenic.
Cardiogenic. Okay, lagi? Apa lagi? What else you're not mentioned? Betul lagi. Obstructive shock, kan? Patient with obstructive shock. Patient yang ada tension pneumothorax. Patient with this cardiac tamponade, obstructive shock. Okay, sebab dia tak ada circulation. Okay, unless kalau patient memang bleeding banyak, that's a different story lah. Okay. Okay, femur, long bone fracture. Okay. Okay, can continue. Teruskan.
Okay, so this is a clinical picture of a patient in hypovolemic shock lah. So for the DCS akan ada altered in mental status like restlessness, disorientation, and then tachycardic, and then patient ada dyspnea. Skin dia akan jadi looks cold, clammy skin lah. And then ada obvious bleeding, it was open wound. And then urine output dia pun akan start to reduce lah. So NBP start to lowish, hypertension. So might need IV replacement dengan blood transfusion lah. So this is the general picture of hypovolemic shock patient lah. So assessment upon arrival tu kita macam biasa, we take a history taking and then we do some physical examination like you know the mental status, the hydration status and urine output so that we can divide the classification of which class it belongs lah. And then we can check for CCTVR, which is skin color, CRP, temperature, pulse volume and pulse rate. So investigation, we can do a baseline, ABG, GSM, and if needed, we can proceed with CO in class 3 and above lah. And then we can do ECG, radiology. So usually we proceed first with the fast scan and then echo and also chest X-ray lah. So this is the overview of the normal EFAS and then we can check for the IBC juga lah. So we go for the management. We have a primary survey. So this primary survey, semester we start with A, B, C, D. So for the airway, ensure the airway is protected and the breathing, we can provide the oxygen. Circulation, ensure that there is a 2 large bore granula lah. And then take for all the investigation. And then disability, assess for the neurological status. And then exposure or environment, address the patient and maintain the temperature. And then adjuncts we can do for the radiology, chest, pelvic, and spine lah. So if there is no sign of shock, then we can proceed with secondary survey. But if there is a sign of shock, then we need to identify where the source of the hemorrhage shock. So if there is a signs of hemorrhage, so we can see the external lah. So kita tengok external dia any open wound ke that leads to the hemorrhage ke. And then long bones, we can do chest X-ray, we can do fast scan and then pelvic X-ray juga. So this can proceed dengan kita punya intervention lah. Contoh if we found any external wound, then with active bleeding ke apa, then we can apply direct pressure lah. And then if any fracture to the long bones, we can put on splint or reduce fracture lah, reduce fracture. And then chest X-ray we proceed with chest tube. Lepas tu if the abdomen kita tengok macam ada intra-ab ke apa kan, so we can proceed with emergency laparotomy. And the true peritoneum, if pelvic X-ray contoh kita nampak macam open book fracture ke, then we can put on pelvic binder lah. And then this is the routine maintenance lah, for maintenance IV fluid. So normal daily fluid requirement is 25 to 30 ml per kilo lah. So kita akan bagi IV drip and then kita reassess and modification. So this is the replacement and redistribution. So existing fluid or electrolyte deficit or excess. So kita can check for dehydration, hyperkalemia, hypokalemia or any fluid overload. If we already give the fluid resuscitation, then we can do the frequent reassess lah, check for any vomiting ataupun NG tube loss, biliary drainage loss, and then dia ada stoma loss ke, and then ongoing blood loss. Lepas tu then redistribution and other complex issues, we can check for any edema, severe sepsis, hyper or hyponatremia or any liver or renal impairment lah. So this is the example that we can give in a hypovolemic shock, example of catecholamines lah. So we have the butamine, dopamine and epinephrine lah. So that's all.
Habis lah. Okay lah. Hypovolemic. Two commonest cause of shock that we deal is hypovolemic dengan septic lah. These two type of shocks you need to know how to recognize and how to treat. So just now yang penting is your CCTVR. Let's say you go to a place, you kerja kat district ke, kerja kat KK ke, where you don't have usage of ultrasound, not available. So then is your clinical assessment. You use your CCTVR. Sama macam yang they advocate in patient with dengue kan. Jadi kita nak manage dengue. Sama juga macam kita nak manage patient yang ada hypovolemic shock. Each time you want to give your boluses fluids or this reassess back your CCTVR because you want to see patient ada any clinical improvement or not. Okay. Ada soalan tak pasal this one, hypovolemic shock? Any questions? Bila kita nak start bagi blood? Bila? Blood. When do you want to give your blood products?
Kalau class 3 and above.
Class 3 and above How about kalau class 2?
Class 2 kalau ada
Class 2, okay. It depends lah. Kalau if it's a trauma patient, kalau class 2, you already can consider to give blood. This one kalau kita deviate sikit lah, talk on trauma lah. Let's say you have a trauma patient. We have a scoring system called ABC score. Okay, so kalau patient trauma, if let's say if it's fast dia positive, or patient ada penetrating injury to the abdomen, patient memang datang dah hypotensive. Okay, this group of patients you can already request blood early. Because you know, if patient is bleeding, you can give a lot of fluid pun, tapi you must know fluids ni dia hanya increase your volume for a temporary while, a short while. So all this fluid you give, dia tak ada oxygen carrying capacity. You tak ada hemoglobin, HB tak ada. So when you give your packed cell, you give blood products, and you improve dia punya oxygen carrying capacity. At the same time, you increase dia punya volume. So one, especially in patients with trauma, is not to delay lah. If you think you need to give blood, you don't delay. At least now in our ED, we have the benefit of having our safe O in ED. So cara penggunaan apa safe O kena tahu all of this, and then when to activate your NTP, all this also you have to know. These are some additional things lah. Okay. Dr. Fairuz nak tambah anything?
Just yang classification of shock tu lah. So like I think Dr. Rafeek cakap, this is very important. So ini memang kena ingat lah. So the reason why korang kena tahu and kena ingat this classification of shock ni, for hypovolemic shock, is mainly partly to determine which fluid you nak start first. So kalau some slide dia akan cakap lah, class 1 mungkin improve fluid resuscitation, class 2 start dengan crystalloid, class 3 you need to start considering blood product, class 4 you memang kena start dengan blood product. This is the sort of patient 3 dengan 4 ni, sometimes this is the sort of patient you nak start safe O. Yang kedua, this class of hemorrhagic shock ni is only applicable to patient yang young patient with no medical illness. For extremes of age, pediatric, elderly, sometimes this classification of shock ni bukanlah useless, it can be misleading. Your elderly patient sometimes is on beta blocker, so they're never gonna get therapy. Kan? They've got multiple comorbid, so mungkin dia ada hypertension, so they never gonna get hypotensive. So you need to start looking at, relative hypertension. So be careful in interpreting classes of shock in extremes of age, pediatric and elderly. This is actually meant for adult with no medical illness. So something to need to be kept at the back of your mind lah. Okay. Lain tak ada je lah. Just the importance of, and it helps with your communication lah. So bila you nak communicate dengan kawan-kawan kan, cakap, okay, I've got this patient, trauma patient in class 3, class 4, shock kan. So patutnya dia terus faham lah apa maksudnya. Tak payahlah nak cerita panjang-panjang kan. Itu je dari saya.
Okay, thank you Dr. Fairuz for your input. Ada soalan, ada any more questions from audience? Ke presenter nak clarify apa-apa? Tak ada lah, the expert lah presenter. Okay, I think everyone can thank the presenter. Okay, thank you very much.
Thank you.
Ustaz tadi siapa? Mak awak ke?